Hi everyone, welcome to my channel Nursing Ed KGS. I'm Keithian. In today's video, we're diving into one of the essential topics for both NCLEX preparation and everyday nursing practice: patient positioning. Whether you're getting ready to write your NCLEX or you're looking to sharpen your skills on the floor, understanding how to properly position patients is key to providing safe and effective care. In this video, we'll cover some of the more common patient positions, their indications, and some tips to remember. Let's get started. So you have a patient that has an above-the-knee amputation. The first 24 hours post-op, you'll be elevating that residual limb on a pillow. And this is going to help to reduce swelling and preventing complications such as deep vein thrombosis as well as contractures. By elevating that limb, you'll also be able to help to ease the pain and the discomfort by reducing pressure and improving circulation in the affected area. After 24 hours, we'll be encouraging the patient to daily prone positioning themselves. By positioning the patient in a prone position, that is, lying on their stomach, for short periods of time throughout the day as tolerated, this will help to stretch the muscles around the hip and promote further proper joint alignment. A myringotomy is a surgical procedure to drain out the built-up fluids from the eardrum. After a patient has a myringotomy, you'll be positioning the patient on the side of the affected ear after surgery to allow for drainage of the secretions. For ear or pulmonary embolism, before, the Trendelenburg position was often recommended for ear embolism. However, recent guidelines suggest that it may not be as necessary or effective in all cases. In any case, if you're a nursing student, you might get asked what is an appropriate position for a patient that has an ear embolism, and it would be Trendelenburg. That would be maybe one of the most appropriate answers in that case. Now, this is where you turn the patient to the left side and you lower the head of the bed. This approach helps to prevent the embolism from traveling to the brain or the coronary arteries, which can be life-threatening. Now, basically, it helps to trap the air embolism in the right atrium and ventricle of the heart. This prevents the air from traveling into the pulmonary arteries, where it could obstruct blood flow to the lungs, potentially leading to, as I said, a very life-threatening situation. It also facilitates aspiration. In this position, if the ear embolism is severe and needs to be aspirated, the healthcare team can access the right ventricle more easily, as the air bubbles are more likely to stay in the lower chambers of the heart. It also increases venous return. By elevating the legs, this helps to keep blood flowing and reduce the likelihood of air bubbles reaching the arterial circulation, which could cause embolic events in vital organs such as the brain. Autonomic dysreflexia is a syndrome that involves an overreaction of your autonomic nervous system. Patients who have had spinal cord injury are most at risk, and it causes a sudden and severe rise in blood pressure in addition to other symptoms. If you suspect that your patient has autonomic dysreflexia, your first intervention is to elevate the head of the bed or have the patient sit upright. This is done for several reasons. One of them is to reduce blood pressure. By elevating the head of the bed or asking the patient or assisting them to sit upright. This will help to lower blood pressure. In autonomic dysreflexia, it causes a sudden and severe rise in blood pressure, which can be life-threatening. By getting the patient to sit up, gravity helps reduce blood flow to the upper body and brain, thereby decreasing the risk of a hypertensive crisis, stroke, or other complications. It also encourages venous pooling in the lower extremities. The upright position encourages blood pooling, which helps decrease the overall blood pressure by reducing the volume of blood returning to the heart. Immediate elevation of the head of the bed helps prevent the dangerous effects of unchecked hypertension associated with autonomic dysreflexia, such as seizures, retinal hemorrhage, or even death. For patients who have asthma or other respiratory conditions, we normally encourage an orthopnic position, and it's frequently used for patients with asthma and other respiratory conditions to expand the lungs and allow for more effective gaseous exchange and allows more oxygen to enter the lungs as well. Post-op below knee amputation. The first 24 hours post-op, the foot of the bed should be elevated. After 24 hours, daily prone positioning for hip extension. Now, if you have a patient and they have a box traction, which is shown in the image on the right, you'll also be elevating the foot of the bed to help maintain the correct position of the limb, enhance the traction's effectiveness, and prevent the patient from sliding. After a cardiac catheterization procedure, keep the site extended. This will help to prevent bleeding or hematoma formation at the puncture site, as well as preventing other complications. Patient has cerebral aneurysm. High Fowler's position is normally suggested, and this will help to reduce intracranial pressure, improve cerebral perfusion, and minimize headache and discomfort. Post-op cleft lip surgery. Mothers or parents should normally encourage to position the infant on their back and ensure that they are using an infant seat in order to prevent trauma to the suture line, support healing, and minimize the risk of complications. You should also encourage that when they're feeding to hold in an upright position. After cleft palate surgery, we normally encourage placing the infant in a prone position to help protect the surgical repair, promote drainage of secretion, reduce the risk of aspiration, and overall contribute to a smoother recovery. If you have a patient with continuous bladder irrigation, the catheter should be secured onto their thigh, as well as their legs should be kept straight. This will help to prevent kinking of the catheter, ensure effective drainage, reduce discomfort, and also facilitate monitoring. So you're able to monitor the flow of irrigation fluid and assess for complications. For enema administration, whether it be fleet enema or soap sud enema, you'll be positioning the patient on their left side lying or Sims position with their knees flexed. Patient comes in and they have a nosebleed or an epistaxis. You'll encourage them to lean forward This will prevent blood from flowing down the throat and so avoid swallowing the blood as well as aspirating on that blood. It will also reduce blood pressure in the nasal blood vessels as well as facilitate effective blood flow management, so the physician is able to clearly visualize the nasal cavity as well as promote coagulation by minimizing the amount of blood flowing to the back of the throat and allowing it to drain out. By leaning forward, it helps to encourage the formation of clots at the site of the bleed in the nasal cavity. Head injury, head of the bed at least 30 degrees in order to help to decrease intracranial pressure. Hemorrhagic stroke, head of the bed elevated 30 degrees. This will help to reduce intracranial pressure, facilitate venous drainage, improve cerebral perfusion pressure, and prevent secondary brain injury. An upright position is normally encouraged for patients who have hiatal hernias. Before surgery for the hernia, by keeping the patient upright, it helps to reduce symptoms such as heartburn or acid reflux, helps to decrease abdominal pressure, and it also helps in keeping and maintaining gastrointestinal function as well as facilitate monitoring. You're able to assess the patient better. Post-hiatal surgery repair, helping to keep the patient upright, will help to reduce pressure on the hernia site as well as support healing and improve breathing. Increased intracranial pressure would normally encourage high Fowler's position. Head of the bed flat for patients with ischemic stroke. This helps to optimize cerebral perfusion pressure, prevent hypotension, and improve the efficacy of thrombolysis and other interventions. A laminectomy is a type of surgery in which the surgeon removes part or all of a vertebral bone. And this normally helps to ease pressure on the spinal cord or the nerve root that may be caused by injury, herniated disc, tumors, or even spinal stenosis. Post-op laminectomy, back should be kept as straight as possible. You'll be log rolling the patient to move them, and you'll need sandbags on the side to help maintain that position. Post-op liver biopsy, patients should be lying on their right side with a pillow or small towel under the puncture site for at least 3 hours after the procedure. If you have a patient with a nasogastric tube, the head of the bed should always be at least 30 degrees in order to prevent aspiration. And you should also maintain the head of the bed at least above 30 degrees if they're having continuous feeding or an hour after intermittent feeding. For patients who are going to be having a paracentesis done, they'll be either flat on the bed or sitting. If you're asked to prepare a patient for a pelvic examination, they'll be in a lithotomy position as shown in the image below. If you have a patient who's receiving peritoneal dialysis and the outflow seems to be inadequate, one intervention you could do is to turn the patient side to side before checking for kinks in the tubing. Post-cataract surgery, the patient should be encouraged to sleep on the unaffected side with a night shield for at least 1 to 4 weeks post-op. Post-op infratentorial surgery, and this is where there's an incision at the nape of the neck. Position the patient flat and lateral on either side. Post-lumbar puncture, the patient should lie flat in supine position in order to prevent headache and leaking of cerebrospinal fluid. Post-op total hip replacement teaching will encourage a patient not to sleep on the operated side. Do not flex your hip more than 45 to 60 degrees and do not elevate the head of the bed more than 45 degrees. You'll also encourage that they maintain hip abduction by separating their thighs with pillows. Postural drainage. This is where we're using gravity to drain the mucus out of the lungs by changing position. The lung segment to be drained should be in the uppermost position in order to allow gravity to work. Patient teaching on preventing dumping syndrome. You'll encourage the patient to eat in reclining position, lie down after meals for at least 20 to 30 minutes. Also restrict fluids during meals, a low fiber diet, and small and frequent meals. A prolapsed umbilical cord occurs when the cord slips ahead of the presenting part of the fetus during labor. This can compress the cord and reduce blood flow and oxygen to the baby. The knee chest position or Trendelenburg is used in an emergency measure to relieve pressure on the umbilical cord and improve blood flow. By having the mother assume this position, gravity helps move the fetal head away from the cord, potentially alleviating compression. It is usually a temporary measure until a more definitive solution, such as repositioning the fetus or cesarean section, can be implemented. Post-op bronchoscopy. The patient should be flat on the bed with their head hyperextended. This will help to facilitate breathing, prevent aspiration, and help keep the airway open and reduces the risk of airway obstruction. For a rectal exam, knee chest position, Sims position, or dorsal recumbent position. Patient has shock, we'll normally do a modified Trendelenburg, as well as encourage bed rest with the extremities elevated at least 20 degrees, knees straight, head slightly elevated. An infant who has spina bifida, you're going to position the infant on prone so that the sac does not rupture. Patient who has spinal cord injury, immobilize on a spine board with the head in a neutral position. You could also immobilize the head with padded C-collar to maintain traction and alignment of the head manually. As well as if you're going to ever move that patient, you should be log rolling the patient so that the patient isn't twisting or bending. So for a thoracentesis, during the procedure, the patient can sit on the side of the bed and lean over the table. After the procedure, the affected side or the side the procedure was done on should be up. So they should lie on their unaffected side. This brings us to the end of the video. Thanks for sticking around. Remember to leave a comment, like, share, and subscribe. And stay tuned for more exciting and educational videos from Keithian Nursing at KGS. Thank you.